Welcome, everybody. This is the Rotary eClub of Silicon Valley. Every week, we bring you programs that we hope will inspire you. Our focus, our triple focus in our club is on innovation, education, and entrepreneurship as they relate to service to others. Service above self is the motto of Rotary International and of our club as well. I hope that if you are new to Rotary shindigs of any kind, you will take a moment to stop and learn a little bit about how Rotary works. You can find out more on our site on this page with this meeting, or you can go to rotary.org, where 1.2 million people from around the world are connected in order to bring good things to their communities near and far. Our program this week is with Dr. Glenn Posner of Ottawa. And Glenn is somebody that I think of not so much as this incredible professional doctor who knows tons about simulations. You just read that in the bio. But as a guy who knows like a lot about rock and roll trivia. Why would I know that? Because he and I were on the same cruise ship, and when it came time at the end of the little trivia thing before the cover band came on, we passed papers, and I got his, and I was like, dang, this guy's really good. And so, after we finished, turned back to him and his wife, Erica, and said, hi, and we got to talking. And so that led to him being here so that he can tell us about the very cool topic of simulation, its possibilities, both for medical education and for disaster preparation. So with that, I'd like to hand it over to Glenn. Welcome to the Rotary eClub of Silicon Valley.
Great. Thank you so much, Rushton. It's great to be here. I'm really excited to talk to you guys about simulation. And I'm just going to start off my slides. So not everybody knows what I'm talking about when I say simulation-based education, but in the next 12 to 15 minutes, I believe you will understand exactly what I'm talking about. Oh, how do I make it? Oh, there we go. I figured it out. Thank you. The beginning of simulation, most of us may have practice on Annie. Annie, are you okay? Somebody go get help. Somebody start CPR. I'm going to do mouth-to-mouth resuscitation now. Resusci Annie was probably the first model that I ever saw, and she's been around since 1960, designed by a toy maker named Laerdal, and the Laerdal company is still making mannequins today. But cut to today, and we have really elaborate mannequins. We've come a long way since 1960, and the medical community has developed very elaborate mannequins, and you can see that in this OR type setup, things are made to look very realistic, and the mannequins have monitors, and you can change their vital signs. And this is where simulation has gone today. Just beyond this image, in a control room, is computers that are running video machinery in the room, running the actual mannequin, microphones so we can talk inside the room. And this all looks really, really exciting, but what is it all for? Why do we have these simulators today? Well, I'll let you in on a little medical secret, which is the way that we train medical trainees, unfortunately, up until about 10, 20 years ago, was the old adage of see one, do one, teach one. Meaning when I learned how to put in a central line into somebody in the intensive care unit, I watched my senior do one, and then once I'd seen one, I get to try the next one. And then once I've done one successfully, I now teach the next person how to do it. Well, that sounds fantastic if you're a learner for independence, but yes, you're shaking your head. That is not a great idea if you're practicing on my family member or me or anybody that I care about or any patients for that matter. So the medical education system is kind of at odds with the patient safety system. So see one, do one, teach one really should be an extinct idea in medical education. What we're really doing with these simulations is putting our trainees in a situation that they have to get themselves out of, that they have to problem solve out of, and building their mental Rolodex of experiences so that when they see it in real life, instead of having to work through the problem, they've already worked through the problem at the simulation center. So they just call up that mental Rolodex. It's very stressful during a crisis to be able to access information that you learned in a lecture. If you actually have experienced it, you've managed this in real life, even though it's in a simulation, you're better able to access that information afterwards. So we're building people's mental Rolodex. After we expose them to an experience in the simulator, we have a debriefing. We talk to them what went well, what was positive, what would you change, your delta, and we talk to them about, little take-home messages or pearls that they would take forward to next time. So we have a really nice debriefing, a reflective conversation. The problem with the healthcare system is that it's a bit of a runaway train. Things are always happening. There's always another patient to be seen. There's always another patient in the emergency room. When I finish doing a delivery, there's another patient who needs to be seen. So we don't have that opportunity to sit around and have a really meaningful, reflective conversation about how we could be better next time. So that's what simulation brings to us. We put people in a situation that they might not see during 5 years of training so that they live through it. Then we reflect upon it so that they leave that experience with an opportunity to apply new knowledge the next time this situation comes up, and then experiment again. Simulation is also an opportunity to teach crisis resource management. So this is an excellent book that kind of changed my way of thinking a few years ago. Beyond the Checklist. Beyond the Checklist means we have brought the pilot's checklist from the airline industry into our operating rooms to make sure that we're doing the right surgery on the right patient. We go through a pre-op checklist, just like pilots do. Beyond the checklist means that we're learning more things from the pilots. The pilots taught us that the way they talk to each other in the cockpit, the closed loop communication, the leadership, the followership, the situational awareness, these skills that are very important in the airline industry are also important in healthcare. We know that in cultures where there's very high hierarchy, it's harder for co-pilots to speak up against a pilot. Same thing in medicine. Very hard for a resident to say something to their staff when they see something going awry. So in this airline accident, I think it was Air Korea, the co-pilot said to the pilot, "Hasn't the radar been helpful today?" And some of you may have read about this from a Malcolm Gladwell book. How hasn't the radar been helpful today? He wanted to say, "Dude, you're about to fly into the side of a mountain," but he couldn't say that. So he said, hasn't the radar been helpful today?" Hoping the pilot would be like, "Oh my God, you're right. The radar has been helpful today. Look, we're about to fly into the side of a mountain." Yada, 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 they flew into the side of a mountain. So we are applying these principles to medicine. If you see something going wrong during a crisis, we are trying to teach residents during simulation sessions that they can speak up, and we're trying to chip away at the culture of medicine through simulation and teaching crisis resource management. My favorite 5 CRM principles are realizing this is serious and actually telling somebody, closing the loop, so sir, yes, sir, very military attitude, that I heard your order. Instead of saying, someone start CPR, somebody go get help, you look at somebody in the eye and say, you, go get help, come back, tell me how long it's going to be until help arrives. That's closed loop communication. Leadership. People in medicine, even though they've been like the top of their class their whole lives, people don't like to say, I'm in charge here. So teaching people to walk into a room and say, hi, I'm the internal medicine resident. I'm going to lead this code. That's very important. Using resources appropriately, looking around the room and saying, you're the anesthesiologist, you're good at airway, you take the airway. You're a nurse, you're good at starting IVs. I want you to start an IV. Tell me when it's done. That's about using resources. And the leader should be standing at the foot of the bed, looking at the entire situation, maintaining situational awareness, and summarizing often. So these are the things that we teach in simulation. So I started my career teaching residents about these issues, teaching obstetrics residents these issues, teaching medical students about these things. And then I started to get into the field of team competence. Oh, I'm sorry, there's a typo. There's no I in team. So individual competence versus team competence. You can have amazing people in a room who are all excellent nurses, doctors, respiratory therapists, But if they can't work together as a team, if they can't use those crisis resource management principles to pull together in a crisis, then it doesn't matter if they're the best people in the hospital, or they maybe not be the best team in the hospital. So I started getting interested in this. And we started taking simulation out of the simulation center into the actual hospital. We know that things like this happen. This is a great video that you should look at on YouTube called Just a Routine Operation. This is about a guy who lost his wife. He was in the aviation industry, so he knows all these issues. He lost his wife because there was a diffusion of leadership. There was an anesthesiologist a group of anesthesiologists who didn't realize that this poor woman probably needed a tracheotomy in order to live through her, this crisis. They couldn't intubate her. They couldn't ventilate her during her surgery. And in this picture, there's actually a nurse who has brought the tracheotomy kit into the operating room. But she kind of like nudges the surgeon with the trach kit, but she doesn't actually say to anybody, guys, this woman needs a trach. So what I'm trying to do in the hospital now is bring all of the principles that I just told you about with crisis resource management with the residents, bring it to the hospital and try to get the nurses to speak up when they see something going awry in the hospital, and have the surgeons and the physicians invite suggestions from the team. So I'll teach the code team during a debriefing, I'll say to them, if anybody in this room had a good idea that they didn't share during the code, I want you to reflect tonight when you go home. What was the obstacle to you sharing that great idea? And for the leaders in this room, I want you to, when you're in a leadership situation, I want you to invite suggestions from the team. I want you to say, guys, this is what I'm thinking is going on right now. This is what I'm doing to treat it. What am I missing? Does anybody have any good ideas? Invite suggestions from the team. So that is again, I'm trying to always just chip away at the culture of the healthcare system. So in 2014, my hospital started this program called the Simulation Patient Safety Program, where we took the mannequins from the sim center, brought them to the hospital, plunked them in a bed, as you see, and there's our tech, Kathy, at the foot of the bed, ready to run the mannequin. And I pretend to be the patient's family member. We hit the call bell, and I say, Uncle Bob's not breathing, somebody come and help. And they activate the real code blue team, and the real code team comes, and they resuscitate my plastic Uncle Bob. And then after they run the code for about 10 minutes, we have a debriefing right in that room. And I say, guys, how did that feel? Anything you would have done differently? What are you happy about? What would you do differently? How can we be better 10 minutes from now than we were 10 minutes ago? So that's our program. And just a few pictures. Here's a mock code blue. You can see, some people wonder, do these people really care about my plastic Uncle Bob? They do. Look at the engagement that's going on in these pictures. This is the debriefing that's happening afterwards, the conversation that we're having to be better. I'm giving you examples of a mock code blue of a cardiac arrest, but you can see my plastic mannequin here in the operating room with real surgeons making decisions about what to do and deciding that this patient is bleeding too much and needs to have a different operation. This is an emergency cesarean section. One of my favorite pictures. These are my nurses at my hospital, and very engaged with moving my plastic mannequin over to the OR table to have a cesarean. You can see my friend in the corner with the baby, ready to hand the baby off. This is the debriefing conversation that takes place afterwards. And I really want to impress upon you, it's not about that cool 10 minutes with the cool mannequin. It's about the conversation. It's about the reflection that takes place afterwards. That's the cool part about simulation. And the skills that it takes to facilitate that conversation are special. Radiology, cafeteria. There I am resuscitating my mannequin in the cafeteria until somebody else takes over from me. And it's an opportunity not just for team training, but an opportunity to identify latent safety threats in the system. So, for example, when I did my first ever cardiac arrest, the actual defibrillator, the machine that shocks the patient, it didn't actually connect well to the pads that were on this setup. So a bit hard to explain, but the equipment wasn't right. So if somebody had actually had a heart attack on that floor 10 minutes from now, it would have been hard to use that crash cart. Not impossible, but it would have been hard. So we're trying to identify issues with the organization and training and maintenance and design of the healthcare system that we wouldn't know about if we hadn't run these sessions. So not only team training and crisis resource management, but and not only chipping away at culture, but identifying latent safety threats that affect patient safety. And we're tracking those and closing the loop on those. And there's really opportunity here. These skills, the mannequin, the whole idea of running a session that prepares you for a disaster. You can do small disasters, you can do big disasters. We did what's called a code orange at my hospital. So a code orange is like a response to a mass casualty, either a mass shooting or so what we simulated was a mass shooting. And then 2 months later at my hospital, there was a horrible bus accident and many patients were transferred to the hospital. And every patient that arrived at our hospital lived. All the patients who were alive when they came to the hospital made it out of the hospital because we had just practiced it. We practiced a code orange in November with pretending that it was a mass casualty shooting. And then we had this mass casualty in January, and we were a well-oiled machine. But I think this technology can be used, or this modality of teaching can be used in dental offices. Does your dentist know what to do if you have a seizure on the table or have an anaphylactic reaction? If you're at a shopping mall and there's AEDs all over the shopping mall, they're well labeled, but this kind of like simulation can be used to prepare office buildings, could be used to prepare shopping malls, could be used at airports, really anywhere. And on a smaller scale, it could be used for just team building exercises. We've had people come into our sim center for sessions. They love it. You get to learn about closed loop communication with your coworkers. So the simulation patient safety program can be deployed anywhere. So my take-home messages are that really simulation is a great way to promote patient safety. It creates this safe space to have a really nice reflective conversation. It's safe for the patient, safe for the learners, because they can practice in a safe space where they can't hurt anybody. I want everybody to know what simulation is. I want people to know that we're doing it not just in sim centers, kind of in vitro, but now we're using it also in vivo, or what we call in situ simulation in the hospital. And that we used to practice just together in, residents in silos, medical students in silos, and now we're all training together as interprofessional for interprofessional education, but going beyond that as well. Please feel free to follow me on Twitter, follow my Sim Center on Twitter, follow our Simulation Patient Safety Program on Twitter. I'm available for questions. Thank you very much. A little bit long. A little bit long.
All good. Thanks.
I meant at the end.
All good. So we have with us five people in addition to myself and the speaker, 4 members of our club, and James, whom our members and perhaps even our guests will remember from our recent program. So good having you here from Kuala Lumpur. We also have Farheen here from Santa Clara, California. We have Roger from Kamloops, British Columbia. We have Nick, who is in Vancouver, British Columbia. And our last person on the group here is Shags, who is in the northern part of the San Francisco Bay Area. Good to have the entire team here. So I will get us started with the questions, and everybody else just flag me either in the chat or with a wave when you're ready to ask questions as well. So Glenn, when you think about the mechanics of getting people into communicating more effectively, you talked about the issues of hierarchy, kind of military style communication, close the loop communication in the actual operation. But there's also how communication works in a debriefing. The same kinds of issues that might keep communication from being effective in the simulation might also keep it from being effective in the debriefing. How do you address that?
You know what? Debriefing is my favorite thing to talk about, because I give courses around the world about how to ask the right question so that you get the right answer from people in that room. There's something called the PEARLS framework, which gives us structure to how we run the debriefing. And the most important part of the PEARLS framework for me is based on the goal of your question, you ask it in a different way. So we talk about directive feedback, and then we talk about advocacy inquiry. Directive feedback is very simple. There's no possible universe in which what the person did was right. So you simply say, I noticed that you did X, next time do Y because the guideline says that that's the best way to do it. I don't care what your frame of mind was. You did it the wrong way. That's not how we do it. And you do it in a very polite, very friendly, like, hey, I noticed you did X. By the way, next time I think you should do Y because the guideline says so. You don't even ask them to respond. But advocacy inquiry is a fantastic technique. This was something that was developed in Boston. In advocacy inquiry, you ask you make three statements. I noticed that you did X. I am concerned because X led to a different outcome than I think you wanted. I would have done Y. I'm really curious why you did X. What was it about the situation that led you to do X? I'm genuinely curious. So the way you ask that question with genuine curiosity, you're not pretending there's a possible universe in which they were right. You're genuinely believing there's a possible universe in which they saw it right and you saw it wrong. So it's really respectful of the trainee, of the person you're asking the question, because you're admitting, I may have seen it wrong. I would have done Y. Can you advocate for your position of why you did X? I want to know your frame of mind. So it's these really little subtle techniques that's the real beauty of debriefing.
Nice. It's always good to set aside our own omniscience, I'm thinking. Definitely. Roger, I know that you had a comment or a question.
Yeah, I have two questions. The first question is that I've dealt with a lot of doctors over the years, and many of them have next to God type of mental attitude. And which I could see in the nursing situation would be a very difficult thing to overcome in terms of communication, so that they would feel like speaking up and that their voice would be heard. How would you deal with that?
You know, the facetious answer is we're just waiting for them all to retire, those people. But the truth is, there's a kernel of truth in there, which is that my generation and the next generation for sure are really the culture of medicine. You know, I say that I'm chipping away in it, but we're really trying to make it. We're really trying to change it to a team mentality. So you're not going to fix everybody. I can think of a great example of an operating room debriefing where the surgeon was just like that. He said, you know, I booked the patient for surgery. She was fine when I booked her. Not my problem. This is an anesthesiology problem. And the anesthesiologist was a young guy, and he said exactly what I wanted him to say, because he stood up and he said, guys, this is what I'm treating. What am I missing? And he invited suggestions from the nurses. So it's partially a generational thing, and you're not going to fix all of it easily amongst the old guard.
Right. The second question is that has there been any studies done of the effectiveness of your simulation training?
So you need to finish that question. The effectiveness, how are you measuring effectiveness? Survival of patients? Happiness?
Very good. No, in terms of the general preparedness of everybody on the team.
Right. So depending on what outcome measure you use, in the early days of simulation, we asked them, did you like it? Then the next level question was, did you actually learn anything? So we would give them a pre and a post test. Then the next level of learning is, does it actually change your behavior? So if we look at your charts, if we follow you over time, if we test you 6 months out, somebody who's been trained in simulation, are you going to perform better than somebody who wasn't? Now, some of those points have become moots. Like, of course, if I bring you to the sim center for intense training, you're going to be better than somebody who got no intense training. So the research question today is more about what kind of simulation, what frequency of simulation, when do you have to come back and do a refresher course? What is the optimal dose of simulation to create an outcome? We believe that it makes a difference. We believe it's the right thing to do. Now we're just finessing what the right dose and frequency is.
Thank you very much.
Pleasure.
Hi, Glenn. Thank you so much for your presentation. I loved really everything you said. I'm applying to medical school next year, so your presentation really hit home.
Good luck.
Thank you. Thanks. So I have a ton of feelings, but I want to make just one comment. I especially loved what you said about see something, say something. And so I actually went to Japan for my master's, and it was fairly hierarchical. And, the Japanese master's students, or, the PhD students, they never really felt comfortable telling the head professors their concern. But as the resident American, I became their advocate because I learned through my experiences that just because I'm younger and maybe less experienced doesn't mean that my ideas or the ideas of my peers are less valid. So I hope to continue speaking up during medical school and hopefully then residency.
Yes.
And I also hope to remember this presentation to ask questions, of my peers, of the other folks in the room, and make sure I'm listening to everyone, especially for the nurses. I really think that nurses don't get enough credit for everything that they do. And just because I'm going to be a doctor doesn't mean I'm the most qualified, really. So thank you. I really appreciate your presentation.
Pleasure. You'd probably be interested in a paper came out last year out of Denmark, a colleague of mine who was talking about debriefing in different cultures. And like I said, I go around the world teaching debriefing, but his point was maybe debriefing, we have this very North American centric idea of how debriefing should go and how that hierarchy should play out. And maybe debriefing in China or debriefing in Japan or debriefing in a different culture is going to have is much different, and we shouldn't judge people, or if you're teaching people how to debrief, say no, that's not the way you ask the question. Well, no, maybe it is the way you ask the question in that culture. So we have to be culturally sensitive in our debriefings as well.
So I have a question around, I could probably ask a whole bunch of questions because I find that this is particularly applicable in many places, and I've used the concept. Like you said, I didn't understand what you meant by simulation training until you went through the presentation. However, now I feel like I can recognize where I've gone through simulation training for my various jobs that I've performed over the many years. And I'm curious if you get pulled upon outside of the medical community to provide and guide in this kind of training.
We're trying.
You're busy to get
We're trying. So I have, I started this program in 2014, and the closest I've gotten to taking my skill outside of simulation, I can answer your question in a couple of ways. I've applied my skills in debriefing to non-simulated environments. So they'll say to me, hey, Glenn, something really bad happened in the OR last week. We need somebody to facilitate a conversation. So it doesn't exactly answer your question, but it's taking simulation skills and applying them, being a good facilitator of a conversation in a safe way. Pretend that what happened was a simulation and ask the same questions in the same very curious, genuine, respectful way. To answer the question you really asked, I've contacted shopping malls And there are companies that actually train shopping guards to do CPR and do ACLS. I ran an in situ simulation in the St. John's Convention Center in Newfoundland. So I pretended that somebody was stabbed at the convention center and went down, and the convention center people knew I was going to do this, but the security of the convention center didn't know I was going to do it. Or like their boss knew, but they didn't know. And the poor security guard ran, and he had to go get the first aid kit, and he called the paramedics. We had informed the paramedics that this was happening. And then we had like simulated paramedics come in, and then we debriefed the security guard of the convention center in front of the entire like conference that we were running. And this poor guy, God love him, he was like really hard on himself. And I was like, dude, you did amazing. You were fantastic, and you're so brave to be sitting up here on the stage. But so it's still a medical context, but that's the closest I've come to like running a crisis outside the hospital.
Thank you. And I can first of all, I cannot imagine being the security guard there. But you mentioned when answering Roger's question, part of the space that I work in is in the data analytics space, and understanding the data and then making adjustments based on that. Is the capturing of the data that do you guys capture data that is, and does technology assist you in understanding that kind of performance that you were telling Roger about?
Complicated question.
And it can be answered at another time too. It's just, I can imagine a lot of wealth, and I just find that everything has data, and it's just about, can you use it? And the answer is maybe not yet, like in the future.
There's so many parts to that question. It's simulation as lab. So people will bring medical students into a simulation center, do very specific, like teach them how to do a lumbar puncture in a certain way, and then test them afterwards. They're collecting tons of data around that, trying to figure out the best way to teach a medical student how to do a lumbar puncture. There's that area of research. Then there's like the system-based things. So how many, like what I'm more interested in now with this in situ simulation is, how many latent safety threats are we identifying per session? And in which sphere are those latent safety threats? Are they in the equipment sphere? Are they a knowledge gap? Are they a system? Are they a problem? Are they a maintenance problem? And then are we closing the loop on those things? That's what I'm more interested in now, is does in situ simulation actually improve patient care? Does it save hospitals money? Because like a whole other branch, I'm fascinated to know if you make nurses feel like they're a more important part of the team, if you listen to their concerns, are they less likely to call in sick? Because I know when I was a junior resident, I was less likely to call in sick when I felt valued. When I was a first year resident and I was useless, I called in sick a lot. When I was a second year, as soon as I was a second year resident, and if I didn't go, like bad things would happen, like I was needed, I never called in sick again. The next time I called in sick was like when my wife was pushing in labor, many years later. So I have a hypothesis that nurses, that employee engagement, that nursing engagement, that nursing absenteeism would be better if we went hard with some of these techniques. But I think that's completely tangential to your question.
Thank you. No, it answered, I guess, the start of it, and I look forward to seeing how it evolves. Thanks.
So my question's a little bit different in the sense that as an international person, looking at the US from the inside, a lot of our information about things like shootings comes from CNN. So, every week there's been a mass shooting almost in the US, and that's how we feel. But if you live in a city, how safe do you actually feel? I mean, what prompted you to do that mass shooting exercise?
I'll tell you exactly what prompted me. There was a guy in Toronto who drove his van down the street and took out a bunch of pedestrians last year.
All right. Yeah.
And when that happened, the hospitals in Toronto and my colleagues in the hospitals in Toronto started tweeting and started saying, you know, we were prepared, we were a well-oiled machine, we dealt with this casualty.
Yeah.
Then I had the thought, listen, I live in the capital of Canada.
Yeah.
We are a sitting duck for a terrorist attack.
Yeah.
So we need to be prepared. So I said to my bosses, you know, I think we're prepared. I think that our In Situ program is preparing people for this. And then I contacted the emergency department and I said, how prepared are we? And they said, well, you know what? It's been a few years since we did a good exercise. Let's do, we do a lot of tabletop exercises of with clipboards, but we've never actually done it with mannequins and with standard patients. Let's do a mass casualty with the emergency room and the operating room. And we did it, you know, we took a half day, we debriefed it like crazy. We did it November 16th, and then January 12th, we had this horrible bus accident.
Yeah.
Hadn't had a code orange in Ottawa in many years. Then 2 months after our drill, we had it. And everybody said, wow, we're so lucky we just practiced 2 months ago. We were a well-oiled machine. That's all you can ask for.
Yeah.
So not as many mass shootings in Canada as there are in the United States, but there still are.
Yeah. Thank you very much.
Pleasure.
To me, Rushton?
You're up.
Oh, I'm up. Doctor, thank you. That was a fascinating presentation. I've always been interested in medicine, except that, you know, chemistry kind of killed me when my professor showed up drunk. I work as a money coach and trainer, and I help people learn how to talk to others around their money circumstances. So we're always into how you ask the question is so important. So I'd like to go back to when you first started answering the questions, and you went through that 4-question debrief, and you said, why did you do it that way? I might offer a suggestion of please share what led you to take that approach. And then rather than I would have, because this is more, it sounds judgmental and putting people on the spot, in your approach, had you considered? So I share that with you as a gift, and thank you for a wonderful presentation.
Thank you very much. It is very hard to talk to defensive doctors sometimes and fragile learners. So you do have to choose your words carefully.
Indeed.
For sure.
Thank you.
All right, everybody. Well, thank you all for participating in our recording. And viewers, thank you for being part of what we've got going today. Make sure you log your attendance below and contribute to the discussion at the bottom. As we always do, I want to hand it back to our speaker for a last thought before we finish our recording. So Glenn, thanks again for being here. Offer up one more thought for people to walk away with. And unmute first.
You know, I first and foremost just want people to know what simulation is, what the goal is for patient safety, and to realize what the healthcare team is going through, and the crises that they face, and the decision making, and the idea of the runaway train, and the lack of opportunity to reflection. We all want to do our best. We're just trying to figure out how best to do that in such a busy environment. And simulation, when I give some talks, I say that simulation it's not going to save lives in a direct manner. It's not necessarily as sexy as curing cancer or curing heart disease. But the problem is, if the resident who comes to put in your central line has never practiced before at the simulation center, you're not getting your chemotherapy if the central line doesn't make it into where it needs to go. And if the person has no bedside manner to run, to talk to you, then the healthcare system is, everybody has a bad experience with doctors that they can draw on, bad examples, bad stories. We're trying to use simulation to change culture and stamp that out. So is
that it? I'm the cue up for I can't tell when you stop. I'm a past president, and I always had to start the applause. So
go the applause. Cue the applause.
Yeah, great program. Sorry, I didn't mean to step on you there.
All good, everybody. Thank you very much for being part of it, and we will see you next week.
Bye.